Welcome to this morning's industry session, directing outpatient surgical site selection using an algorithmic approach and connecting digital pathway, sponsored by Smith & Nephew. Smith & Nephew announced its ARIA digital care management platform in August. ARIA is a connected care solution designed to make your staff more efficient, streamline care decisions, and lead your patients to a life unlimited. Today, we're proud to announce here at AAHKS the addition of ARIA Site Select and optimized recovery pathways as new features to the ARIA platform. Please welcome this morning's faculty, Dr. Ritesh Shah, Chief of Orthopedic Surgery at Advocate, Illinois' Masonic Medical Center, and Dr. Nishant Shah, anesthesiologist at Midwest Anesthesia Partners, as they join us from Chicago to discuss these new features and benefits included in ARIA.
Hi, welcome. Today we wanted to talk to you about the ARIA platform and looking at ARIA to harmonize the recovery with ARIA Site Select. Importantly, ARIA is a product that was developed by clinicians for clinical use. I want to introduce the faculty for today's program before we really dive deeper into ARIA. My name is Ritesh Shah. I'm a Chief of Orthopedic Surgery at Advocate, Illinois Masonic Medical Center that's in Chicago, as well as part of a large musculoskeletal group called Illinois Bone and Joint Institute.
Hi, my name is Dr. Nishant Shah, and I am the anesthesiologist that works with Dr. Shah a lot, and I am also a partner with Midwest Anesthesia Partners.
So what is ARIA? ARIA is a connected care solution designed to automate patient communication, streamline care decisions, and lead our patients to a life unlimited. Essentially what ARIA is the interconnected nature of taking care of patients. In its current form, ARIA is a digital care management solution. It includes customized pathways, patient engagement, coordination of all the providers, care navigation capabilities, predictive costing, and patient-reported outcome measures collections. This is really critical to total joint replacement surgery. As we know, total joint replacements are being moved from the traditional inpatient care, which is in the hospital setting, to outpatient care, whether that's in the ambulatory surgery center setting, where patients are going home the same day, or in the hospital outpatient setting, where patients are going home the same day. And the goal of the ARIA digital care management platform, a digital care management pathway, is to allow for patients to be taken care of in a way that's customized, that's engaging, and that's coordinated across all their providers, while at the same time allowing for predictive costing and collection of good outcome measures. The future of ARIA goes even farther. And today we're going to be focusing on one part of this, which is the patient selection algorithm that's present in the future of ARIA. But the interconnected nature of ARIA also means there's other things that are included in the future of ARIA. And those include telemedicine, telephysical therapy, and integration into the electronic health record.
One of the things that I want to talk about today is patient selection criteria. All of us know that patient selection criteria is deemed to be one of the most important characteristics when it comes to patient selection, of course. All of our conferences, all of our seminars, all of our webinars in this new climate that we're in talks about patient selection criteria and the need to pick out certain characteristics that inhibit a patient from being an appropriate candidate. Some examples are given here on the slide. What we've been taught is that these are the 5 or 10 or 15 or 13 most important characteristics that we need to look at when we evaluate a patient. Furthermore, we are told that there are contraindications that are absolute reasons for a patient not to be an appropriate candidate, such as certain cardiac conditions, morbid obesity, untreated obstructive sleep apnea. What our intent and goal here is to show that patients cannot be evaluated in a vacuum. They cannot be evaluated based on one condition or another, but in reality, we need to look at them as people that come in all different sizes and shapes. They are more so a composition of all of those characteristics. They are an aggregate of all of these different situations rather than one unique condition or another unique situation. They have different comorbid conditions, and those work together comprehensively to present a different patient no matter the situation that they are in. And these patients have different needs. They have different things to think about when evaluating them. So when we evaluate these patients, if we are looking at them as an aggregate and a composition of all these different characteristics, we have to have a way to objectively classify these patients. Otherwise, we'll be using anecdotal evidence, we'll be subjectively using our experiences to evaluate patients, and there won't be a real basis for which to have a unified manner in which to think about them. So we need to consolidate these patient characteristics and the aggregate of all of their parts into a very concrete, objective manner. And that's why we need a tool to help elucidate how to characterize patients for the outpatient setting for total joint arthroplasty, as is what we're talking about today. And so what's a good way to objectively classify any piece of data? That's an algorithm. It uses objective data, it compiles the information along with processes, and gives you a binary result based on the data that was inputted. And then it helps to present this data in an understandable, easy to use fashion. And if that's what algorithms do, why not apply them to patient selection? If we apply the principles of algorithms to patient selection and use the objective criteria that we input and use the aggregate of all of that data, we can help determine which patients are appropriate for the outpatient setting. Furthermore, if its basis is in medicine, it is no longer subjective, but based on objective data and evidence-based research. It also then allows us to disregard bias from my experience or my colleague's experience or different situations we may have been put in. Now, once we classify these patients objectively again, we need to think beyond that objective classification system. Because once the patient has been directed towards the outpatient setting, we need to have an appropriate way to take care of them. Because once we select a patient, we need to know how to take care of them. So it is not enough to say that XYZ patient is an appropriate candidate for the outpatient setting for an outpatient total joint arthroplasty based on our objective criteria, but we now need to have objective methods of how to take care of that patient.
So one of the important tenets of total joint surgery right now is this migration from traditional inpatient care to kind of alternative, more innovative outpatient care. And we know that right now that percentage of patients that undergo total joint replacements out of an aggregate pool in the United States is a small percentage in the outpatient space. However, the projections are that over the next 3 to 5 years, that growth in the outpatient space is going to be exponential. With that in mind, we recognize that one of the most important tenets to make sure that you have success in the outpatient total joint arena is that you select patients well. And that's one of the big reasons why the algorithm in site select within ARIA can help objectively classify patients that may be appropriate for the outpatient setting. Again, the ARIA platform, as it relates to the site select portion, was developed by clinicians for their clinical practice. So now, when we look at the systemic process for a successful outpatient total joint replacement, there's a few steps that are involved here. Number one, and most important again, is patient selection, and making sure that again you objectively are able to select patients. We know that there are many times where in a practice setting, in a subjective sense, a surgeon may decide that a patient is a candidate for an outpatient total joint, or a surgeon may not decide they're a candidate for outpatient total joint. And many of those decisions are very subjective. And so the algorithm allows it to be objective and avoid that sort of gestalt that a surgeon may feel. On the other hand, it still allows that surgeon to make their final clinical decision in terms of selecting a patient. Number two, it's preoperative consultation and preoperative medical clearance, and making sure that the process for preoperative consultation and appropriate medical clearance is again verified and comprehensive. Number three is making sure that you do a good job planning preoperatively and planning in terms of templating specifically for your total joint replacement patients. Number four is preoperative physical therapy, specifically focusing on things like gait, balance, stair climbing to get ready for surgery. Number five is preoperative home setup. We know that one of the most important tenets of total joint replacement surgery, especially over the last 5 or 6 years, has been coordination of care to avoid patients from having complications such as readmissions, falls, periprosthetic fractures, or other things. And so having a good preoperative home setup can avoid those things. You notice that 5 of those steps out of the 8 are pre-op, and so there's a lot of planning that's involved. Number 6 is intra-op. A lot of things are done within surgery. We all know that surgeons all do things a little bit differently, and many surgeons are doing things very innovatively now. But making sure they follow soft tissue preserving techniques, and that implant choice we know makes a big difference. And so bearing surface like actinium can allow patients to have less of the complications with metal on metal issues, which are non-existent with actinium. At the same time, have longevity, which we know in multiple registry data points that actinium and the hip in particular has been shown to have increased longevity comparison to others. Number 7 is anesthesia and the pain pathway, and you'll see sort of very specific multimodal pain pathway that's involved as dictated through our anesthesia colleagues like Dr. Shah. And number 8 is postoperative physical therapy and sort of the function on that. So in the preoperative education piece, the single most important tenet is when a patient normally sees a surgeon like me, and especially if we're meeting them for the first time, and let's say they're coming in to discuss a total joint replacement, they have a lot of anxiety and a lot of fear around the surgery. And so we want to make sure we discuss that anxiety and fear right on, sort of be direct about it and explain to them what it means in terms of the total joint. Education, we know, reduces anxiety more than anything else. Number 2, many patients, specifically on knee replacements, have this worry or fear about pain. And so really working with them on an expectation of pain. Our data has suggested that pain with a total knee replacement on the day of discharge for same-day total knees is a 2 or a 3 out of 10. So it's not that exorbitant amount of pain that patients are worried about. We know that on post-op day 1, their pain remains about the same, about a 2 out of 10, so it's manageable. Again, it's not a 0, meaning they don't have any pain, but it's also not a 10, the worry that they have. Then we talk about their expected length of stay. So in the same-day total joint, especially in the ambulatory surgery center setting, we know that reproducibly our patients are able to be discharged and go home about 2 hours after surgery, meaning they've walked, they've climbed stairs after the surgery, and they're heading home under the guidance with a physical therapist. And then what does it mean to be satisfied? A lot of the total knee replacement literature demonstrates that understanding satisfaction is really critical. And so understanding that, explaining to them what limitations they may or may not face. And then most importantly is universal messaging. I as a surgeon can say something, but then if every other provider in that cascade doesn't follow the same messaging, the patient's confidence can turn back into anxiety or fear. And so universal messaging becomes really important in the pathway. We know that all preoperative medical clearance is not the same. And so understanding the variability and quality and addressing that variability and quality of the medical clearance is important. And what ARIA serves to do is help in terms of helping understand what a quality medical clearance entails. Again, still allowing clinical decision making to be made by clinicians. What does it mean to be malnourished? We know that decreased protein levels like albumin can affect wound healing, length of stay, and it applies equally to obese or thin patients. So it's not that one patient population or worse is better than another. And so it's important to kind of look at that. We know smoking can increase cardiac and pulmonary complications, can increase anesthesia risks, can increase things like wound complications. So addressing smoking and working on tobacco cessation preoperatively is important. There's been multiple studies demonstrating diabetes, specifically in diabetes type 2 and following hemoglobin A1C levels as a effect for minimizing risks such as surgical site infections, deep infections, periprosthetic infections, or wound complications. And then narcotic minimization. This has become a big focus in healthcare over the last couple of years, the opioid epidemic that has affected kind of the United States, and really working with patients on minimizing the use of narcotics. We know that narcotic use affects both short-term, mid-term, but also long-term outcome after a total joint replacement. So here's a good slide on what preoperative multimodal analgesia entails. As you can see in the oval that's colored brown, expectations are really where most of this starts. So you're going to start on preoperative education. It really is the most important tenet for multimodal analgesia. And the focus on this is about mobility. It's not just about pain control, but it's helping patients understand that early mobility is going to actually help them reduce pain. And so building that expectation preoperatively at multiple levels in your universal messaging is really important. Number two is a use of an anti-inflammatory, such as Celebrex as a brand name, that can be used if a patient can tolerate that. It's a really important way to reduce inflammation, reduce pain, without jumping into the narcotic landscape. There are some surgeons that can use neuromodulators. Personally, I don't use them because of an increased fall risk, and recent studies from the anesthesia literature have kind of corroborated that. However, neuromodulators such as Lyrica or gabapentin can be utilized in some multimodal analgesic pathways. Then a short-acting, low-dose oral narcotic. Again, really important. All those terms are really important, right? So not IV medications to avoid the peak and valley that kind of comes with the IV medications, but a low-dose, short-acting oral narcotic kind of providing a baseline pain control that allows, again, that patient to get up and walk. The focus being walking and mobility, not just pain control. And then regional block, which is really important. And so Dr. Shah with the anesthesia care really provides an excellent regional block with adductor canal block on our total knee replacements that allows those patients to get excellent anesthesia care without any of the potential motor blockade that can affect, once again, ambulation, because the focus of this is early mobility. It also eliminates the need to use catheters, and we don't have to worry about tourniquet use if we use them on knees. I also think that in addition to what you see here, we do use a pericapsular injection, which is a concoction or a cocktail of medications that addresses not only pain, but also inflammation and reduces and allows vasoconstriction to, again, minimize pain after surgery without narcotic utilization. When we think about doing outpatient total joint replacement, composition and a recruitment strategy also becomes important. So now if you look at a center that's about to either embark on the journey of doing a total joint or potentially go from a center that's doing small volume total joint to high volume total joint, you have to look at your composition and recruitment strategy very well. And so the single most important piece of that composition and recruitment strategy is a committed surgeon or a group of committed surgeons. And we know that. They're the ones that are doing the surgery. They're the ones that are identifying patients. They're also the ones that are kind of saying, when am I as a surgeon comfortable to move from the traditional inpatient care to the outpatient arena? Secondarily, you want to make sure that a scrub nurse in the operating room is very familiar with a total joint. And so hiring or training a great scrub nurse that can do this is important. It allows the surgeon to feel comfortable with the migration to the outpatient total joint space, but also allows a scrub nurse to be able to train other nurses in the facility to be able to go from, again, low volume to high volume, which we know based on the data that is coming. And we know high volume total joints in the outpatient space is coming to us in a couple of years. We know the nurses can train others on the procedure, but also the post-op nurses can focus on one-on-one patient care. So again, having a scrub nurse and having a lead nurse can train a lot of others in the post-op care. A lot of times resources that are available from your implant companies like Smith & Nephew can allow you to have education in this same world. So sort of how do you deal with efficiency, migration, and education towards this, like you're seeing today. And then again, changing the mindset of everybody in your facility. This is not about pain control. It is about early mobility, early ambulation, right? And finally, there is an economics to this. And so the economics to this is to kind of understanding your cost and making sure that when you think about staffing, that you hire enough initially, but then as you grow, you should know you will need to hire more staff in order to kind of go from low volume to high volume, but you'll do that appropriately. So then we talk about patient flow. And again, the important tenet in the outpatient arena is that you're moving from a different way of taking care of patients. It's not the traditional care of inpatient hospitalized care, which is where a patient has surgery, then they go up to the floor and they get a totally different care pathway. In the outpatient arena, everything is very close. And so those patients are going to get care that's one-on-one, which is a really important tenet of this, which then impacts your flow, so impacts your throughput. And so preoperatively, scheduling becomes important. Scheduling based on anesthesia type, nursing flow, and physical therapy, keeping that in mind to make sure that your total joints are done in a way that allows those patients to get one-on-one care, have appropriate throughput, and then be able to be discharged in a timely way where they're doing well, they're satisfied, but then they're ready to go. So the next patient in that cycle also gets good personalized care. With the personalized touch in the outpatient arena, you want to make sure these patients get good communication. That includes preoperative phone call, making sure that the insurance authorization is taken care of well. Check-in is done well and done efficiently and done caringly. Preoperative nursing is done really well to make sure that a lot of the anxiety that patients come in with is kind of put to rest and that they get educated in the process once again. Anesthesia care, I can't speak enough about anesthesia care and the importance of it, making sure that it's invariable, making sure it's personalized, and making sure that the anesthesiologist is also really engaged in the care of that patient, because it's a completely different mentality from a traditional outpatient, in the traditional outpatient space compared to the traditional inpatient space. The surgical team has to understand the importance of personalized touch. Your postoperative nursing, postoperative physical therapy, and home therapists are all engaged, right? So the idea that this entire team knows universal messaging and is really patient-centric. Throughput, can't speak enough about this. At our center, we went from low volume to higher volume, and throughput was really important because it allowed that one-on-one care, which was really important for patients. You cannot have these patients feel like they're part of an assembly line. It is a different care pathway, and they're coming to you for that outpatient one-on-one care. Again, having objective goals for ambulation is important. The patient needs to understand that on average, patients are getting up between 30 minutes to 40 minutes after surgery. And so pain is going to be reduced once they get up and walk. And a lot of our patients now actually communicate that themselves, where they come out of the OR and once they're ready, they say, you know what, I'd rather like to walk. I have some pain, I know walking is going to help. Your postoperative communication is really critical, and having a timeline for postoperative communication is really important. Calling that patient, and they should know they're going to get phone calls around a particular time so that their needs can be addressed. One of the important questions that I get asked all the time is outpatient total joint replacement safe? And so we've published on this, as have some others, and outpatient total joint replacement performs very strongly in comparison to inpatient care in terms of safety. And in our study, we demonstrated that it is safe. We know that there is amazing accountability and excellence in the vertical team that's created for outpatient total joints. We know that variability is minimized. We know there's reliable communication, both in a forward and backward direction, to make sure patients are taken care of well, even after patients are discharged and even after patients are admitted. So kind of in that pre-op, intra-op, post-op piece. We know that surgeon processes and surgical technique has become really refined and is taken care of well. As I spoke about earlier, anesthesia care is invariable, it's excellent, it's focused on mobility, and they're very engaged in these processes. Home physical therapy, home nursing is taken care of really well, again in the preoperative and in the postoperative sense. And then outpatient physical therapy, they understand because they're seeing these patients sooner than they ever have in the outpatient arena. And so they also are educated on how outpatient total joints do and what sort of things they should look out for in case there are any issues, to make sure that's communicated to the patient and to the care team. You have to identify and align all the stakeholders that are involved in outpatient total joints. And so it's an interdisciplinary team. The blue circle there, the patient is the center of this team, right? And so the team involves the surgeon, the anesthesiologist, the nursing care, the physical therapist, and the administrator. But everybody's a part of this, and everybody has a stake in this, and they all have to be engaged to make sure that patient does well. It's a very patient-centric method of doing things. So with that in mind, if you'd like more information on this, or if you have questions about this, and you want to look at ARIA Site Select, please visit think-aria.com for further questions. Now, with this in mind, we'd like to kind of delve deeper and show you how to use ARIA Site Select. And we're going to select 2 patients, and Dr. Shah is going to take us through this, but I'd like to keep this in mind. We know that last year, Medicare allowed outpatient total joint replacements, specifically outpatient total knee replacements, to be done in the ambulatory surgery center. And so the average patient demographic changes with that. And so with that in mind, I'm going to allow Dr. Shah to go through 2 patients. And keep in mind, these patients are not your traditional sort of cherry-picked patients for outpatient total joints. They're a patient that have a composition of medical and social and functional issues that he will go through.
Thank you, Dr. Shah. I would like to now talk about those 2 patients that he was referring to. And I want to give you a little bit of an introduction before we actually get into the site select algorithm for patients for outpatient total joints. As he mentioned, normally, when we started this outpatient program, what we wanted to do was pick patients that we knew would be appropriate candidates, and in that regard, did not have any real comorbidities and were very healthy patients. As he mentioned, as we kind of go through this process and as we get further and further along with Medicare and with other things that are changing in the world, we realize that we cannot only choose patients with no comorbidities. And what we wanted to do is make sure, what we as physicians want to do is make sure that we're taking care of patients safely and appropriately. And so what the site select algorithm helps us to do is to take control of this situation and look at patients kind of comprehensively with multiple comorbidities, but in an objective fashion, as I mannered, such that even though they have comorbidities, they are still safe for the outpatient setting. And with that, I'd like to go to the site select page and kind of walk you through these 2 patients so you know how it works. So the first patient we're going to look at is a 73-year-old with a pre-existing history of hypertension and who also had a transient ischemic attack about 18 months ago. The good thing for this patient is that this TIA resolved and there were no residual deficits, both motor and sensory. And so what we do is we go to the site select algorithm page here in the ARIA platform, and we click the appropriate categories. And as you can see here, there's a lot of different categories for medical comorbidities that a patient can have. They are macroscopic categories that then get more specific. And what I'll do here to show you is I'll click on pulmonology here, even though this patient did not have a pulmonary condition, just to show you that there are many conditions that then populate. So I'm going to take that away. And what I've done here is kind of auto-populate, or what I've done is populate the patient's condition so we can begin to move forward. So as I go forward, the algorithm then begins to load, and what we have is a series of questions. So does the patient live alone? We know that that's not the case. Does the patient use a wheelchair? And we're now looking at the functional status of the patient. And the reason this is important is, again, we're looking at the aggregate situations and comorbidities of this patient versus just separate comorbidities in a vacuum. Does the patient use a walker or a cane or crutches? And the answers to these questions are all no. Now this patient is 73 years old, as I mentioned, and so we'll select that. And the patient's BMI happens to be 36. And now we get into the neurological history. Has the patient ever suffered a stroke or a TIA in this situation? And that answer is yes. And as I mentioned, it is not within the last year. And as I mentioned, there were no deficits. This patient's blood pressure happens to be 132/88 on medication, and so we can answer in that fashion. And then once we're done selecting all or answering all the questions, we can click complete. and we can review our answers to the questions that were populated, and we can calculate a score. And as we can see here, this patient has a score of 90, and that green dot there suggests that this patient qualifies for an outpatient total joint arthroplasty in the outpatient setting, as I mentioned. Now, this information has to be taken into account with the total comprehensive picture that the clinician will use. And as we mentioned, this was made for clinicians, by clinicians in the clinical setting. And in the clinical setting denotes that we have to take all the other information that we may have at our disposal and use this very important information in the context of that. And now I would like to present another patient, which happens to be the average age patient in America right now for total joint arthroplasty. So we now have a 63-year-old female who has diabetes type 2, who also has CKD stage 2 as a result of that diabetes, and who has an existing diagnosis of depression. And so again, I have pre-clicked the categories that represent the information that I presented, and I'm now going to go through the site select algorithm. This patient, again, does not live alone, is not in a wheelchair, does not use a walker, but happens to use a cane, and, as I mentioned, is 63 years old with a BMI of 34. This patient has CKD stage 2, chronic kidney disease, but does not have end-stage renal disease, so I will click no there. The patient is not on dialysis, but again, has chronic kidney disease, and it happens to be stage 2. The mental illness category here is a yes, because depression fits into that category, but does not have schizophrenia or any of the anxiety, bipolar, panic, or post-traumatic stress disorder, but does have depression. This patient has diabetes type 2, which is non-insulin dependent, and as a result, I will go through the algorithm in this fashion. And the hemoglobin A1C reading for this patient was 7.0. So I do have a hemoglobin A1C reading, and it is below 7.5. I will now click complete on the algorithm. Again, I will review the questions and my answers to make sure that I've done it appropriately and correctly, and I'll calculate a score. And now you can see that this average age patient in America for a total joint arthroplasty does qualify for outpatient total joint arthroplasty with this score, with the site select algorithm. And this is based on objective data that is based on evidence-based medicine, excuse me. I'd like to thank everybody for watching this webinar, and thank you for your attention in regards to the site select algorithm and the pathways and kind of the concepts that we were discussing today. I'd like to thank my colleague, Dr. Ritesh Shah, for his very nice words and comments about anesthesiology, which as an anesthesiologist, we don't hear too often. So thank you, I really appreciate it, and I'd like to hand it over to him now.
Nish, thanks. Again, thank everybody for joining this. I hope you found it informative. I think one of the important things about ARIA is the interconnected nature of how it's going to allow for patient care to be done in an objective and digital format. And we look forward to kind of helping help patient care and patient selection in the outpatient total joint arena.